Hi, this is Minnis Joannides, the Chief Medical Director at Optimum Re, and today we're in the Optimum Academy with video Pulmonary 101, video number 3 on chronic obstructive pulmonary disease, or COPD. So what is COPD? It's a progressive lung disease that commonly includes elements of both emphysema and chronic bronchitis, causing shortness of breath. It's usually due to a long history of tobacco smoking. And what do we use to treat it? We use inhaled medication. Sometimes oxygen may be required in order to help the patient who has COPD. And in our case, applicants who apply for life insurance. One of the tests that we use is pulmonary function tests. And they may show a dramatic reduction in lung function, which is not completely reversible with inhaled bronchodilators. And the key and important factor in COPD and underwriting for life insurance is that it can have a significant adverse effect on mortality risk when underwriting a life insurance case, especially if the applicant continues to smoke tobacco. So these are terms that are old, but they still have application. What's the difference between chronic bronchitis and emphysema? So you can see the body habitus looks completely different in these pictures, right? So on the left, the applicant who might have chronic bronchitis would have chronic productive cough with purulent sputum. So the sputum that the person coughs up has color to it. They might have hemoptysis, mild dyspnea initially, but may progress to cyanosis, or their lips may look like they're blue due to hypoxemia or a low oxygen level in the blood. They might have peripheral edema due to cor pulmonale, which is right heart failure due to their lung disease. They might have crackles and wheezes in their lungs and prolonged expiration when they try to blow out a breath. And they may be on the obese side. So how does that differ from emphysema on the right? Those applicants would have shortness of breath or dyspnea, minimal cough compared to the productive chronic cough of the chronic bronchitic patient. They have pink skin, and what they do is they use pursed lip breathing, or they purse their lips to provide a back pressure so that the breathing tubes stay larger so they can exhale more air. They may use their accessory muscles in their chest to take a breath, so it looks like their whole chest wall is being utilized to help with their breathing. They may be cachexic, or have lost a lot of muscle mass, a lot of weight. They may be very thin. They appear to have a barrel-shaped chest due to hyperinflation or air that's trapped in the lungs over a long period of time. They may have decreased breath sounds, and they may have rapid rate of breathing, or tachypnea. Below you can see in the complications they may have a pneumothorax due to the bullae that they may have in the upper part of their lung, and those are like little balloons in their lung that can pop and cause a pneumothorax or collapse of the lung. And they really do a lot of work of breathing, so it takes a lot of calories for them to breathe, so they may lose weight. So emphysema, they may have these blebs or bullae in the upper lobes that I mentioned, and these can rupture and cause a pneumothorax. So at the bottom left, you can see what these bullae look like. They look like little balloons. And then in the middle picture, you can see that these bullae are located at the upper levels of the lungs. And if one of those pops, the whole lung can collapse possibly. So that can be a major problem. Because they have so much lung damage, and these balloons or bullae, they have less surface area for exchanging oxygen. So they have a low oxygen level possibly. The lungs are overstretched and hyperinflated, they can't get the air out. So that's why it's an obstructive lung disease on exhalation. They can't blow that air out. Since the airways collapse from the loss of structure, so the air gets trapped in the lungs, and that's that barrel chest we mentioned, and that's why they do this pursed lip breathing. So you can see, compared to a normal chest x-ray on the left, the lungs are the black areas on both the right and the left. When we look at a chest x-ray, we actually look at it as if the person is facing us. So the little L, the yellow L, is the left side of the chest. So that's to our right. And the right side of the chest is to our left. And that's the black areas with the lines running across are the ribs. You can see the heart right in the middle. Compare that to the x-ray on the right, which shows a long, elongated lungs. You know, they're very tall, and that's what happens in emphysema. You get hyperinflation, or the lung is overexpanded, and it has this long look, and sometimes the lungs take this barrel shape. So let's talk about pulmonary function tests. One of the tests we're interested in is the forced expiratory volume in 1 second. So how much air can the applicant blow out in 1 second when they're really trying as hard as they can to get that air out as fast as possible? So when you look at this graph, on the left, the y-axis, you see how much volume in liters is able to be exhaled. And then at the bottom on the x-axis, you can see time. So we have marked off 1 second here. So in 1 second, how much air can the applicant blow out? And you can see that in a healthy person, or that black line, they get almost, or at least most of their air out in 1 second, right? So that's a normal looking curve. But the gray curve of the person with obstructive lung disease, you can see that in 1 second they get much less air out. So they have a reduced forced expiratory volume in 1 second, or a reduced FEV1. So that would be typically found in somebody with obstructive lung disease like COPD. Now, I put in a red box. This is an excellent report. This FEV1, it was predicted that the person would blow out 2.46 liters in 1 second, and they actually blew out 2.96. So that's better than normal. They were 120% of normal. That's great. We would like all the applicants to have FEV1s like that. But a lot of times the FEV1 is significantly reduced percentage. And often in the patients that I used to take care of, they had less than 1 liter. They only maybe had 400 cc's, or 4/10 of a liter of FEV1. So they were severely compromised. When people are that ill with emphysema, they have a life expectancy of less than 5 years. They may need supplemental oxygen, and they're at risk for all kinds of infections on a repeated basis. They can have bronchitis, pneumonia, influenza, or all kinds of things like that. So they're always at risk. They need immediate treatment with antibiotics if they get a bacterial infection, because they have such little reserve available. One of the features which is available now is oximetry. So a little device is clipped on the finger, and it'll tell us the saturation of oxygen in the blood. And it's much easier than what we used to have to do, which was draw an arterial blood gas, stick a needle in somebody's artery in their arm, withdraw blood, and then take it to the lab to measure the oxygen levels. This somebody can actually clip on and then walk around with it, and we can determine the level of their oxygen even when they exercise. Now, if you think about it, if you want to deliver medicine to the lung, that's where the lung disease is, what's the best way to get it there? So if you take a pill, the pill has to go all through your digestive tract, and then it goes to all parts of the body, so only a small portion would ever get to the lung, right? However, an inhaler, when you use an inhaler or a nebulizer or something like that that makes aerosolized particles, they go right into the breathing tubes and right into the lungs. So you're delivering the medicine right to where you want it, in the pulmonary tissue. And typically, inhalers use a bronchodilator type inhaler for COPD, which may have a reversible component. And we use what's called beta-2 agonists, or short and long-acting drugs that cause bronchodilation or opening up of the breathing tube if they have any reversible obstructive component. Some people with COPD really don't respond to much medication because they don't have much of a reversible component because they have chronic disease that's kind of fixed. But some people have a portion of their obstructive disease which is reversible, and a beta-2 inhaler would be helpful. So that's what's prescribed. What's important is the inhaler particle size. Medications that are delivered via inhaler or nebulizer, the particle size needs to be in the 1 to 5 micron size. If it's less than 1 micron, it may just remain suspended in the air and not deposit in the bronchial tree, which is where you want it to stick and then have its effect. So there are short and long-acting bronchodilators. Short-acting bronchodilators are often called rescue inhalers. And that's things like Ventolin, which has been around for decades, and that causes immediate effect on the breathing tubes to help open them up. Long-acting bronchodilators, which are used on a regular basis once or twice a day, are long-acting and only used on a chronic basis, and not if somebody has an immediate shortness of breath. So you would use rescue inhalers for some immediate episode, but you would use the long-acting bronchodilators on a regular basis every day at the same time, once or twice a day, as prescribed. Then we also have steroid inhalers. Some people profit from having a steroid inhaler or adding a steroid to their regimen, and that may be used once or twice a day, like budesonide, Pulmicort. And then there's anticholinergics, which also can be added and may have an effect. So what drug companies do is they mix and match a long-acting bronchodilator, a steroid, and possibly an anticholinergic, come up with their own combination and then market that as the wonder drug to treat COPD. If you see it advertised on television, it costs a lot of money. So the newer ones that are advertised, you can expect them to be very expensive. And they may be some combination of 2 or 3 of these medications. So 2 that you may have seen on APSs are Trelegy, which is a combo of 3 drugs, a long-acting bronchodilator, a steroid, and an anticholinergic. And it's 1 puff once a day, and the cost is very expensive. And then there's Symbicort, which is a combination of a long-acting bronchodilator and a steroid, and that's 2 puffs twice a day. So one of the things you have to do with these inhalers is read the instructions very carefully on how they're administered, how you prepare the inhaler to deliver the dose, what the dose is, problems with the inhaler itself, if it's been dropped or it lays on its side. So you have to read the instructions very carefully, and often the applicants or patients who use these don't use them correctly because they didn't read the instructions, or their doctor or the nurse didn't explain exactly how these were to be used. So when we look at underwriting COPD, what's important? Well, you want to look for any history of tobacco smoking, right? And if they're still smoking that's a major problem. And of course, tobacco smoking is also a risk for lung cancer. So you'd want to make sure there's no evidence of any lung cancer when they were applying for life insurance. Occasionally on an APS, you may see in an non-smoker mention of early or mild COPD, and it's just the way that the radiologist read it, but they may not have any evidence of emphysema when you look at the rest of their APS. It just happens to be there, and it may be of no consequence or significance or require a rating. If you have a pulmonary function study, you want to look for the FEV1, or the forced expiratory volume in 1 second, to assess the degree of obstruction when they try to exhale. So based on that FEV1 and other key factors, you can make a decision on how severe the disease is. And then severe shortness of breath on any exercise, inability to walk up steps, or the use of nasal oxygen are all adverse findings. And as we mentioned before, severe COPD can have a life expectancy of less than 5 years. So that would be a candidate that we may not want to make an offer on. So that completes our video number 3 in Pulmonary 101 in the Optimum Academy. Join us for the rest of our series on pulmonary disease.